Hello friends, welcome to Quick Dentistry, solution for your dental subjects from first to final year. Subscribe the channel to learn your subjects fast and don't forget to press the bell icon for new video updates.
Today we'll talk about TmJ ankylosis under the following headings: Introduction, Classification, Etiology, Clinical Features, Diagnosis and Treatments. So first let's go with introduction. So ankylosis means a steep joint which occurs by the union of cleaner fossa and the condylar head. Let's go with the normal anatomy of the TmJ. The TmJ is divided into three compartments. It is a freely movable joint between a glenoid fossa and the condylar head. And I am drawing two views of TmJ. The right one is the coronal view and the left one is the sagittal view. The upper compartment is known as the temporal compartment and the middle one is known as the articular disc or meniscus, and the lower one, which is nearer to the condylar head, is known as condylodiscal or inferior compartment, and the articular disc have two bands in it, that is the posterior band and the anterior band. So here we are done with the normal or general anatomy of the TmJ with the both coronal and sagittal view. Now let's take a look at the ankylosed TmJ. What happens in the ankylosed TmJ? There will be either fibrous formation or bony formation which will attach both the glenoid fossa and the condylar head, and we call it as the ankylosed. It's time for the classification. It is classified into two categories. One is false ankylosis and the second is true ankylosis. False ankylosis occurs due to some muscle spasm or due to myositis ossificans or coronoid process hyperplasia, which don't cause any ankylosis indirect. These are indirect causes. And there is a true ankylosis in which there is a fibrous formation or bony formation inside the capsule, or you can say in the compartments, and which is known as the true ankylosis, that may be fibrous or may be bony. The second classification we can get is the intracapsular or the extracapsular, that is inside the capsule or outside the capsule. And the third one is unilateral or bilateral, that is if it's affected one side of your face or the both the sides of your face. And the last one is the partial or complete, that is it has affected the total capsule or it has some partial effect. Now let's take a look at the etiology or the causes of ankylosis. First one is trauma. Trauma during the forceps delivery or blow at any younger ages, or infection from parotitis or tonsillitis. Inflammation due to rheumatoid arthritis or you can say osteoarthritis. Sometimes it's congenital also, and sometimes it's idiopathic. Let's take a look at the sequelae. There is impaired facial growth if it is not treated in a proper time. And if there is impaired speech, you can talk, maybe you can't eat properly, or there may be some respiratory distortions, and there will be malocclusions with crowding of teeth, and there will be poor oral hygiene leading to periodontitis and gingivitis. Now let's look at the clinical features. So clinical features, I can divide it into either unilateral or bilateral. So let's take a look into unilateral patient and a bilateral patient. What will see the clinical features? If you'll observe a unilateral ankylosed patient, then you will observe that there is a facial asymmetry. So we can divide the face into two halves. One is affected half and the other one is unaffected half. And in unaffected half, you can have flatness of face and receded chin. And if you'll observe the mouth opening, then there will be a less mouth opening, that is less than 35 mm. And if you observe the affected side, then there will be roundness of face. And if you observe the chin will be diverted to the unaffected side, and there will be concavity near the chin. And if you'll see the antigonal notch, then you can clearly observe that there is a clear or well-defined antigonal notch. And similarly, you can find some intraoral findings like crossbite and class 2 malocclusions, or you can have periodontitis or gingivitis. So next, if we'll look at the bilateral side, if you'll see a bilateral ankylosed patient, then clearly you have a lower facial height, which is a peculiar feature, and a narrow maxilla, and there will be micrognathia, and there will be unable to open the mouth, that is less than 5 mm, that which is the interincisal distance, and there will be less neck chin angle, which is a peculiar feature of bilateral ankylosis, and there will be well defined antigonal notch, and there will be intraoral findings like class 2 malocclusions with anterior open bite and multiple caries and periodontitis and crowding. Now let's see how we can diagnose the ankylosis. We can diagnose it by OPG or orthopantograph, or the lateral oblique view, or cephalometric view, or CT scan. Now let's see the treatment. We treat to release ankylosed mass and recreate the gap, and recreate the functional joint, and improve oral hygiene, and reconstruct and regain the vertical height. And the most important is the prevention of recurrence. Now let's see the surgical techniques. The first surgical technique is condylectomy. When there is a fibrous ankylosis or there is a partial ankylosis, we perform a horizontal osteotomy cut with the help of surgical burrs, which will create a gap and there will be functional joint. And if there is a bony or complete ankylosis, then there will be two horizontal osteotomy cuts, one at the glenoid fossa and second one at the neck of the condyle, so that there will be 1 to 1.5 cm gap, and that is called gap arthroplasty. And to prevent recurrence, we place an intrapositional graft between the condylar head and the glenoid fossa, so and that is known as intrapositional arthroplasty. So what are the intrapositional grafts? Like, let's take a look at it. Intrapositional grafts may be autografts, that is costochondral graft, or the sternoclavicular graft, and the second one may be heterogeneous, or the cartilage of bovine, and the third one is the alloplast, that may be nylon or Teflon. Some additional surgeries we perform coronadectomy if the opening is less than 35 mm, and temporally myotomy.
Thanks for watching.